Hi, everyone. I'm Cassandra McCullough with the Association of Black Cardiologists, and I am honored to present the Heart Health Equity Champion Award to Dr. Isilma Fergus, Associate Professor of Medicine, Director of Cardiovascular Disparities, and Director of Hypertension and Clinical Lipidology at Mount Sinai School of Medicine. The Heart Health Equity Champion Award is given to recognize a healthcare provider who has served as an advocate for heart valve disease equity. This award honors Dr. Fergus for her impactful work educating people at the community level about heart health, including heart valve disease, addressing health equity issues that impact risk factors, detection, access to treatment and outcomes, and encouraging people to ask questions and advocate for their own and loved ones' heart health. Dr. Fergus's inspiring career, deep commitment to minority-focused cardiovascular research, and ongoing work with the Association of Black Cardiologists are exceptional. As a previous president of ABC, and through her numerous professional endeavors, she has had a great impact on the future careers of aspiring cardiologists. Prior to her current position at Mount Sinai, Dr. Fergus has served as Chief of Cardiology at Harlem Hospital Center for 3 years. She has authored numerous articles related to heart disease in peer-reviewed journals, including her contribution to cardiovascular disease in ethnic minorities. Her current research and clinical interests involves cardiovascular disparities, hypertension, heart failure, and heart disease in women. She has been an investigator in several clinical trials and founder and director of multiple Healthy Hearts projects, including Harlem Healthy Hearts and Montserrat Healthy Hearts, involving education, demonstration, and screening for chronic conditions that lead to heart disease. Dr. Fergus, thank you for being such an important influence on heart health equity issues. It's wonderful to be with you today and to present you with the Heart Health Equity Champion Award. Congratulations.
Thank you so much, Cassandra, for such a kind introduction. I feel truly humbled to be here today, accepting this wonderful award. It's so gorgeous and beautiful, but it really represents a thank you for something that I love to do, my work in the community, educating, demonstrating, as you talked about, with these numerous projects. And it's so needed because when you look at statistics for heart disease in the United States, you continue to see African Americans and communities of color that continue to experience earlier heart disease, more significant or worse outcomes compared with others. And here in the United States, where there's so many resources, there really should be something that we continue to do about it. And so I'm happy to do that. In particular, I'd like to thank the Alliance of the Aging for choosing me to be the recipient. I'm thankful for the work that they continue to do, and the Association of Black Cardiologists. The ABC has really formulated who I am. And based on my earliest memories of being in the ABC, I always recognize that the ABC continues through its mission, vision, and goals to reach out to underserved communities to ensure that heart health is premier, being presented to the communities in terms of improving their education and outcomes. So I was influenced at a very early age with the ABC. And as it relates to heart disease, a lot of people are still not aware and don't know the outcomes, or don't even know that heart disease is 80% preventable. But when it comes to heart valve disease, even less people know about what heart valve disease is about. And that's really something terrible and something that we have to change, because more than 25,000 people a year are likely to die from heart valve disease. So once again, thank you for my wonderful award. I accept it with pleasure and with humility. Thank you.
I would like to ask you a few questions regarding the work you're being recognized for. First, for our audience, please define health disparities and health equity. Do you think that these concepts are sometimes misunderstood?
Certainly, I'd be happy to do so. And that's a great question, because these terms get thrown around all the time, and there can be some misconceptions. So first, let me start with the health disparity definition. A health disparity is a difference in health status, healthcare access, quality, and utilization that occurs based on social racism, ethnicity, gender, education, income, geographic location, or disability. And a health disparity is a fundamentally unfair in terms of policy, design, and practice. And I look at it as the thing that we need to fix, whereas equity, on the other hand, is the thing that is helping to fix the disparity. But I think the confusion sometimes happens between equity and equality. Equity and equality are not the same things. When you think of equality in terms of what's being provided, let's use an analogy. Think of three boys trying to look over a fence at a game, let's say a baseball game. And we have a very tall boy, a medium-sized boy, and a very short boy. They're all given one box the same height so that they could look over the fence. And the tall boy doesn't need it because he can see over the fence. The medium boy, it helps him to just be able to see over the fence. But the little tiny boy still is unable to see over the fence with the one box. So they were all given three boxes. Equity, on the other hand, would mean that in order for all three to see over the fence, the little one is given two boxes. And so now with the two boxes, he is on the same level, eye level, with all three boys who can now look over the fence and look at the game together. So that's the difference between equality and equity. And as I mentioned, equity is a solution to healthcare disparities which occur. And another example would be, Cassandra, when we think of the social determinants of health, which really has to do with where one lives, their access, who they are, and we talked about race and culture, et cetera. What are the solutions in order to solve these issues? And one major one, of course, is health literacy. And that's particularly challenging in our healthcare, because let me just give you an example. Almost 48% of patients with hypertension or diabetes had inadequate health literacy. So simply improving health literacy is an equitable solution to reducing the disparities that occur with some of these cardiometabolic risk factors, and certainly with heart disease. Thank you.
We know that Black adults experience risk factors for heart valve disease, such as high blood pressure and heart failure, at an earlier age than whites. Please tell us more about that and what it translates in detection of heart disease or heart valve disease among Black people.
Yes, you are absolutely right that, heart disease may be present earlier in Blacks compared with whites. In fact, when you look at certain risk factors such as hypertension, which I like to quote because it's a low-hanging fruit that we can fix. And so many people here in the United States are affected with hypertension and don't even know it because it's a silent killer. But Black men and women are more likely to have high blood pressure, for instance, at an earlier age. In fact, more than 1 in 2 Black men and women who are adults have high blood pressure. And high blood pressure, as you know, can lead to heart failure. Heart failure could result in an enlarged or dilated heart, which then leads to a type of heart valve disease.
While we know that Blacks tend to be younger when they develop heart valve disease risk factors, less is known about whether healthcare providers are detecting and treating heart valve disease in these patients. One study found that the odds of being referred to a cardiothoracic surgeon for treatment of heart valve disease were 54% lower in Black patients compared with whites. African Americans with severe symptomatic aortic stenosis, a common type of heart valve disease, also received less surgical and transcatheter valve replacements than would be expected. While Blacks represent 13% of the US population and 11% of Medicare population, only 3 to 4% of TAVR or transcatheter aortic valve replacement patients and 4.8% of surgical patients are Black. What are your thoughts on how to address the significant disparities in referral and access to interventions?
Yeah, thank you. That is just such an important fact. So just to restate that, Blacks make up about 13% of the US population when you look at demographics, and 3 to 4% of TAVRs. That is certainly a stark disparity. We were talking about disparities earlier. And so this is a multifactorial issue to deal with. So referrals, when they do happen late, and there are not many referrals, and there are multiple reasons for this. When it comes to general patients in general, they have to be referred in by primary care providers who I've actually heard them say that they're loath to refer some of their patients into some of these medical centers because they don't come back. So they're looking at it in terms of being able to maintain their practice, which is, of course, their livelihood. And now there's also patient-based, reasons why early referrals don't happen. So there may be some trust factors within certain communities that, warrants people not going in to be seen earlier or letting themselves be referred. There's also lack of education. So they don't really know what they don't know. And, only 3 out of 4 people who ended up having a valve issue even knew about it. Some of the valve conditions, so to speak, may be asymptomatic for a while, and they're not picked up unless people are having regular visits and someone actually listens to your chest and hear a heart murmur.
So what closing message do you have for researchers, clinicians, and patients on heart valve disease and health equity?
So that's a broad question, but it relates to what I was just talking about before. So if we could talk about each one of them separately, let's talk about the researchers. So first of all, we talked about what demographics look like here in the United States, 11% Blacks. Unfortunately, many times in doing research and in the clinical trials, we don't have adequate representation of Black and Brown patients in these clinical trials. So I think researchers have to make a conscious effort to ensure that there's diversity and inclusion in terms of clinical trials, so that when recommendations and guidelines are being created, we know that we have had, adequate inclusion to really say that this treatment or this device or this mechanism actually works for this group. So that's important to recognize. And I just talked about the clinicians. We have to ensure that clinicians actually are educated and that they care. I'm talking about the primary care physicians in the community. But I submit to you that physicians and clinicians, even in an academic center, learning has to be had. And some of this learning has to do with understanding one's ethnicity and culture to reduce prejudices and stereotyping based on prior expectations. And as we talked about in terms of equity, ensure that these patients who oftentimes have more cardiometabolic risk factors and have other issues like social determinants that need to be addressed, that actually more time and not less time would be spent with these patients, educating them about what they need to do so that they can manage their health together. And then as far as the patients, of course, there are a lot of, patient barriers. We talked about some of them before, like trust and literacy. But ensuring that, there's information and education within the communities at a level that people are interested in, meeting them where they're at their local community centers, churches, continuing with some of the programs, for instance, that the Alliance and the ABC have engaged in. I know that, last year we had an event at the Harlem State Office building where community members came out and really enjoyed, and that was a joint event between the ABC and the Alliance. And we got to talk to people one-on-one, answer questions, show them and read with them literature, pieces of literature or brochures. So, continuing activities such as this one would be helpful. So again, I think you have to take each one separately and address each one, the researchers, the clinicians, and the patients, in order to reduce barriers and to, engage in adequate and helpful strategies that will, help to reduce the disparities that continue as it relates to heart valve disease in America. Thank you.
Dr. Fergus, thank you so much for your time and extraordinary work. And congratulations to you on this much deserved honor.
Thank you. It's absolutely been my pleasure to be here with you today. Again, thanks for this award, which I receive humbly. And, I just like to do the work that I do, and I hope to continue to do so. Thank you very much.